Nā mihi nui ki a koutou. I tū ana ahau ki tōku maunga o Taranaki. Ka te tiro whakararo ki tōku awa tawai o Mihirao I riri ana ki te moana te tai o Rehua. Ki reira tōku waka, te tōku maru, e noho ana ki Mohaka Tino. Ka huri tōku mata ki tōku marae o Urunui, ko tō wahi e nohia ia oku tupuna, ko manaia te tangata, nana nei ta iwi te keke riwai hi whakaruru hao ia Ngāti Mutanga. Tēnā rawe atu koutua ki tō wā nāia nei. So thank you very much for having me speak today. This is, I think, a landmark event and highlights so much of the mahi being done for Rongoa, for our people. My disclosure is that I've been a hospital-based doctor and surgeon my whole life, and so in some ways that's a strength, but in many ways it's a limitation. But what I wanted to do today is kind of describe the journey that I've been on and call out some of the people who have helped me on that journey. And really, anei te whakatauki ki te kingi Māori. This whakatauki, many of you will know, it's famous. It's really about setting aside differences and past conflicts and creating an enduring partnership, which really survives to this day. So when I was younger, I was treated with rongoa, and it was very much part of our daily life. And I always kind of wondered, well, you know, why isn't rongoa more visible in the hospitals? And all of you know Article 2 of Te Tiriti, and there's, you know, there's the Māori and the English translations, but both of them, both the Māori and the English, really talk about property and ownership rights, and rongoa is a taonga, and that property and ownership, if you want to use those terms, means that it still lies with Māori, and at least the Te Reo translation recognises the status and authority of rongoa. And rongoa in healthcare, well, there's always been rongoa practitioners. And you know, even after the Tohunga Suppression Act, they never went away. They were always very much around and part of people's lives. Rongoa has been available in primary healthcare as opposed to secondary or tertiary care, if you want to use those terms, since at least 2000. And my colleague Reece wrote a thesis on that, and we heard the fantastic work that ACC has done in the rongoa space this morning, and I still think that that's phenomenal that a government department is able to move so quickly and so nimbly. But what about public hospitals? All public hospitals, of course, have to comply with Te Tiriti. That's written into the health legislation. But many, well, all of them have Māori health support services, and many of you will probably work for those services. But rongoa hasn't been very visible in those spaces, and I always wondered why the gap. And so that was the answer that I usually got. I don't know, it's too hard. It's too hard to make it work with Western medicine. But if anyone's here from the Hokianga, the hospital there, yeah, Tautoko, awesome. Founded, runs on rongoa principles. There's, you know, rongoa mara works incredibly well. So I kind of carried this with me for most of my career. And in 2016, I read about Glenys Mark, who couldn't be here today. Glenys had just completed a postdoc PhD with HRC funding in rongoa. And I made contact with her, and she kindly agreed to meet with me, you know, a colonised hospital-based surgeon. Through her, I met Donna Kerridge. Many of you will know Donna. She's running one of the other concurrent sessions. And then Amohia has also been a huge help in this journey. And so together those three wahine toa have gradually opened, you know, the world of rongoa to me, and that's been a huge privilege. So really this talk is about that journey. So When Glenys and I first met, we met several times, at least 5 or 6 times, and just talked about what to do. But we agreed to work together. And neither of us was interested in measuring or assessing rongoa. There's this real drive in Western medicine to trial things. Is kawakawa better than Maxilon for nausea with chemotherapy and all that kind of stuff? We basically both took the point that rongoa and Western medicine were in and of themselves sound and had mana and motahaki. And instead we look at how would it work? How would they work together? What would we have to do? And what problems would we have to solve? And we have resolved to review all the available literature. My organisation has a staff of 6,000, and to have a little look at how they felt about rongoa. And develop a collaboration model for rongoa and hospital-based care. So that was really the aim, and then to maybe trial that model. So this is what we did first. So what were the factors that would influence a collaboration between rongoa and Western medicine? And this was kind of a literature review, really. Not a lot of literature in the space back before 2000, 22 publications, 7 journal articles, 10 master's or doctoral theses and 5 research reports. I think the lack of publications really reflects the rigidity of kind of the European publication model, which is 3,000 words, 2 or 3 tables and maybe a figure or 2. The rongoa does not fit into that space, and most of our publications have been technical reports which we've written ourselves and posted on ResearchGate, because you cannot distill rongoa into 3,000 words. There's really too much going on. Well, we found 3 themes and many sub-themes. So the first theme was, what about the interface between rongoa and Western medicine? That's kind of the zone of inflammation, if you like. You'd have to be able to justify it, and I think we've heard evidence this morning that you can definitely do that. There's some compatibility solutions. Western medicine is very much about measuring things and licensing things and all of that kind of stuff. There's training. So how would you train, and who would you train? Would it be Western practitioners or rongoa practitioners who would work together? What about standards and regulations? That's viewed as a kind of Western construct, but actually Mataranga Māori has its own standards and regulations, as we all know. There's definitely sovereignty issues. We don't want rongoa colonised. It doesn't need to be subsumed into Western medicine. It needs to exist as a discrete and mana holding entity. There's also an issue with rongoa sustainability. If we provide services in public hospitals, do we have enough rongoa practitioners to provide that service? Will it be just acutes? Will it be elective patients? Will it be outpatients, inpatients? Will it be 24/7? Ideally, possibly, but you have to build up to that sort of service. Who will get it? And what about future research? What questions do we as Māori want to ask in that space? And then there's this push, does it combine with complementary and alternative medicines? So those are things like Ayurvedic medicine and Chinese medicine, traditional Chinese medicine. Or is it, rongoa mana whenua? Is it the traditional medicine of this land, and does it stand separate from those? Implementation of a collaboration, well, that's tricky. Finance, I drove down with Mahuia Goza this morning. Many of you know her. If the practitioners of a service in Te Whatuora are not paid, the organisation will not value the service. It will not recognise it. But rongoa works on koha, so that's a very difficult issue. I think that rongoa practitioners are professionals and should be paid in a manner that befits their status. What about procedural pathways, interactions between rongoa and Western medicine? We have a Māori pharmacist who we work with, but that's a significant thing, particularly from the Western medical side. Ongoing evaluation, honouring Te Tiriti, and a patient-centred approach. In spite of the rhetoric, many of our hospitals are actually process-centred, not patient-centred. Who has the choice and who can access rongoa? Is it Māori only or everybody? We saw great evidence this morning from ACC that actually what's good for Māori is good for everybody. We need to empower the patient to be able to make those decisions and not be directed. And there's a negative perception amongst Māori and probably rongoa practitioners of the public healthcare system. So those were the three work-on areas that we had. Looking at our own organisation, 6,000 employees through all levels, from the people that run parking right up to the chief of surgery and the chief of medicine. So the ethnicities of the people that work there are largely unknown, and we have an interesting area because we serve Decile 10, the very wealthy areas, and also Decile 1 and rural and urban communities. 15% of our patients are Māori. That's pretty standard across the population. A little bit less Pacific patients. They mainly live out south rather than west. 18% of our patients come from the Asian subcontinent, so that's predominantly India and China. We sent an anonymised survey. We were able to get approval to do this via email to all of the staff. There was 8 weeks for people to return it, and we sent 3 reminders. And those are the 2 research questions that we really wanted to know. So what was the knowledge of staff around rongoa? And what opportunities were available and did they want available? So those are the results. Those are the responders. I think it sort of confirms that, hospitals are built on nurses, mostly female workforce, and huge numbers to provide care for our patients. We got a little over 1,000 responses out of 6,000, which is not too bad. 18% responders from who identified as Māori, and 2/3 were either medical practitioners or nurses. So that was the first question that people answered, and perhaps surprising, a lot of familiarity with rongoa. And also, this surprised me too, rongoa is not just plants and herbal medicine, but a whole array of different treatments, and many people surprisingly kind of recognised that, and many had accessed it for other people in their family as well. So just looking at that, so had they recommended rongoa Māori for other patients? Yes, they had. Again, surprising numbers. There is a selection bias in people who respond to surveys. And those were the things that they'd recommended to other people. So, as we all know, there's this, not underground, but rongoa never went away, and there's a very active rongoa community in all our communities. So that none of this is new. And so, that one, those that thought rongoa should be in a district health board setting, again, self-selected group of responders, but most people thought yes, they should. I put up these comments because they're kind of useful. Most of them these are the reasons why that people thought that rongoa shouldn't be in the DHB setting. There's one there about witchcraft. I think that's 3rd or 4th. I've got to put that in. Some of them are quite thoughtful, incompatibility of medical science with spiritual paradigms. That's probably true, but really sad that people think that way. And, the last one about regulation of botanicals and things like that. So some of those were actually quite thoughtful. This one, who should be offered rongoa Māori? Again, all self-nominating patients really won that, and I think that speaks to the ACC experience. So, both of those I thought were pretty interesting. And my own thoughts were that rongoa practitioners should always provide rongoa in the hospital, and most people thought that. So that solved a couple of kind of questions for us about, what a collaboration might look like. And so many wanted more information on rongoa, and that was kind of the thoughts they wanted. Obviously people's time's precious, so many wanted internet-based education, but there's definitely an interest out there. So the next step was to kind of go and talk to people, and Glenys really led this. So we had 14 healers, 12 patients, 9 hospital staff to look at what were the collaborative issues. The hospital staff came from people who self-nominated with the survey, and we did 2 huis, and this was starting to get into COVID now, so the second hui was online, but it at least kept us occupied. So, and also what was the best model, what did a good model look like? We then disseminated that model back to the participants and came up with a final collaborative model. And so in terms of collaborative practices, these were the things that people thought were kind of important. Collaboration between healers, a solid, respectful relationship, patient-centred treatment, and education for staff and patients. The benefit and need for rongoa collaboration, patient benefits, beneficial to Māori, the community and the country, and also a lot of really heartfelt sentiment about honouring the Te Tiriti. And not all the patients were Māori in this too. And then collaboration considerations, so protection of rongoa, particularly things like IP, and getting subsumed into Western medicine. And then you've got to say it, medical resistance to rongoa as well. So this is kind of what we came up with. We spent a lot of time kind of drawing this just to kind of think what were the issues and how would everything kind of sit together. And you can see that protection and medical acceptance of rongoa, that's very important. Got to be patient-centred with choice and treatment and probably available to a wide number of patients. Very important collaboration values, respectful relationships, kind of humble curiosity, if you like. A full and equal partnership. Again, rongoa not subsumed into Western medicine, and knowledge sharing. If we each hold a handle of the kete, we can do things better. So surgeons. Surgeons are very conservative, usually male, usually white, usually old, and they're the last people to change. We don't embrace change very well. This is Nasia Thompson, who's a first-year graduate health surgeon in Ōtautahi. She's one of our Māori graduates and previously been president of Te Oranga, which is the Māori Medical Students Association. She did this without insulting anyone from Ōtautahi. Christchurch, I think, is the most English New Zealand city. It's quite conservative. The hospital's quite conservative. It's very good. But she talked to surgeons there, the whole surgical department, about whether they would be willing to cooperate with rongoa practitioners and clinics. And this is what she got. So they had a limited understanding, and they acknowledged that. They were very open to collaboration, wanted improved education and communication, and they acknowledged there was barriers to integration. She also talked to some rongoa practitioners, and some of you might have even been spoken to her. They prioritised these things, so awareness, genuine collaboration and education, recognising a need for cultural competency and understanding on the surgical side, also the barriers and the complementary practice. So that kind of surprised me. I think I felt quite optimistic with that, and that has been submitted as a publication. So certainly on the surgical side, there's an openness and a willingness, and I think an understanding that not everything we offer our patients works. It's not that, doesn't always work. It doesn't cater for the whole patient. So really the last thing that we did is this Te Mata Hauroa. Most of you know that was Kupe's initial waka on his voyage of discovery to Aotearoa. Glenys and Amohia and I had a hui down in Palmerston North, and we came up with this, the idea being that, perhaps this was an initial voyage somewhere, and that if we carried on, then, we would do Ngā Toki Hauroa, which was the the revised version, the renovated version of the waka that he then later brought back. So this was really our idea of a trial, not in a sort of in a Western sense, but very much in a Māori sense. We chose outpatients because that's easier than inpatients, and looked at a trial of rongoa and Western medicine. So essentially that was Donna Kerridge and I working together with a small group of 6 patients. Those patients came from my outpatient clinic list, so I already had a relationship with them, Donna didn't. We saw them simultaneously, so in the same space at the same time. We did 3 8-weekly appointments over 6 months, and we saw them in the hospital grounds, but in a building that wasn't clinic. It was a separate space. It was a nicer space. It looked out on Lake Pupuki. We had 45 minutes per appointment. That'll give hospital managers a heart attack. Most patients get 10 or 15 minutes, but 45 minutes is really important, I think. We started with karakia and whakawhanaungatanga. It was interesting, very much so in the first appointment. By the 3rd appointment, it was just like, hey, kia ora, how's it going? So that, once we really got to know the patients, we didn't need to do that every time. Whānau came and was welcomed, and we also had food. So it was, really nice way to see patients. And then we did structured interviews with patients and practitioners. And Donna and I spent some time together beforehand, and we came up with those things based on the surveys and what patients had told us, but it was very much a sort of stab in the dark as to whether that would work. And we just kind of sat down and thought, do we see patients sequentially in the same site? Where do we see them? We'd initially wanted to actually do the clinics at Marae, but again, it was coming out of COVID, and so a lot of those spaces weren't easy to access. So we didn't do that. Those are the patients. 6 of them. They're quite a diverse group. There's some Māori, Pacific, and also Pākehā. I thought it would be really difficult to recruit patients for this. In fact, it was really easy. Those were the first 6 people on my outpatient list that I rang, and they were all like, yep, cool, that sounds really great. The Pākehā guy is, he won't mind me saying it, he's a Westie bogan who said, oh, geez, I don't know, that sounds a bit, but okay. And if you talk to Donna, he became a firm friend and absolutely converted to this because he'd had quite big surgery and was really quite traumatised, I think, by the loss of autonomy and self-regulation that goes with being a surgical patient. It's a very passive process. You just have to float through it, and I think he really hated that. But Rongoa was able to help him. And, we did some prescribing in that time and would just basically sit with a patient in whānau and see how they were doing, troubleshoot any problems, and then come up with a combined treatment plan. So it was only a small number, but it was good. So again, kind of did a qualitative analysis at the end. And so these were the sort of things, these are some quotes, I won't read them out, but there was a real benefit of the Rongoa medical collaboration to participants, and I think it was a more holistic way of treating people. There were no time pressures. They could bring whoever they wanted, they could talk about whatever they wanted, and we were just there to help. So that was really big, and that's the Pākehā guy. He'd actually become nearly suicidal, I think, which I didn't know as a surgeon because you're just looking at X-rays really. But he was so traumatised by the whole process. So, excuse me, there's a really high value in healer-doctor relationships. I think the optics of seeing a Western medical practitioner and a Rongoa practitioner working together in the same space for a patient in whānau and mutually respectful each contributing to the best plan, the best treatment for that person was immensely powerful. And I think patients, very quickly realised the significance of what they were seeing. So again, 2 quotes. That's really the patient's point of view. Again, we used the word ecosystem. So, really wasn't. It was about the patient, but it was about their whole ecosystem. And as the previous speaker said, that's really the Māori. How are you doing? How's the whānau doing? How's everything else going? What can we help with? Gave a much better care outcome, I think. Theme 3, best of both worlds. That's having us in the same room and working together. That's really important. So the perceptions, this is the quotes from Donna. I thought this would be difficult. I thought it could be really quite awkward. Although, I love Donna. She's kind and good and never made me feel uncomfortable, and I hope I never made her feel uncomfortable. But it was really easy. The chemistry just worked. And so it wasn't hard to be in the same space at all. It wasn't hard to have conversations. And we didn't agree all the time. You never do. But we could have those conversations. So theme 5, this is the ecosystem of the patient. You were not just looking at an X-ray or a set of blood tests. You were looking at a whole ecosystem and that whole Māori. So, that was me. I got a much deeper understanding of my patients, the challenges that they faced, and, what I could do to help them. And that was Donna. We were people talking to people with different gifts, that's all. So that's that mutually respectful, mana-enhancing relationship. And then the final theme, this is Dwayne. I thought that he might not last the distance. He's been great and stayed in touch. So it would help a lot of people. And I think the previous speaker has really emphasised that our work has to be deep and broad and wide and really thoughtful. It was the right thing, I think, to open it up to people other than just Māori, and probably maybe not all Māori want rongoa, but there's a definite demand for it amongst non-Māori. And then, so suggestions for the future. We want more. How do you fund this? I don't know. Hospitals are built on 5 to 10 minute appointments, not 45. But we'd do a lot better if we spent more time with our patients and thought more deeply about all the things that they need and how we can help them. So, I wanted to leave a little bit of time for discussion because we're sort of at a what now phase, really. We've developed a collaboration model which actually worked on a small scale and in outpatients. And we've confirmed, I think there's a willingness of rongoa practitioners and medical practitioners to work together. Probably not everybody does, that's fine, but it's feasible and possible, and both sides, I think, are open to it. And patients love it, especially in hospital, which tends to be quite mechanistic. We've contributed a small trial. And then along with Hui Goza, we've applied for some HRC funding for a larger trial in oncology in Kirikiriroa and Tāmaki to look at rongoa practitioner support of patients, again, probably as outpatients, but possibly as inpatients. Quite how that works, quite how many people and what resources we'll need, we don't know, but I think the right thing to do is just to scale this up. We know it works, and now I don't think there's anything more to study. We just need a service. It's really where we're at. So I've got to acknowledge these people. Glenna Smart, who's not here, she's uncompromising into a colonised Western Māori surgeon. She never let that affect the project. She always prioritised Te Ao Māori. Donna Kerridge, she's super kind, oh God. And she opened the world of rongoa. And Amohia, I don't know if Amohia is here, but we had the benefit of her wisdom and knowledge. Everything we wrote would go to Amohia last for for review. And boy, she can review stuff, I tell you. And the Health Research Council, government organisation, but they never, I thought they might flinch from funding something like this for all the obvious reasons, but they never flinched. And they've been very generous in supporting us. I wanted to put this up sort of last. So this is, a friend of mine is exhibiting at the Biennale in Venice this year, the Art Biennale, and this, as some of you will know, from Te Mata Aho Collective, it's called Takapo, which are woven truck straps. It's the first piece of art you see when you go into the Arsenale, which is it's an old arsenal down in the port area where all the art's displayed, and it catches the early morning sun, as you see there. So that won the ultimate prize, if you like, in Venice. The other work that won, which was a piece by Archie Moore in the Australian Pavilion, Archie's from Queensland, an Aboriginal artist, is called Kith and Kin. It's a huge work, and I couldn't take a photo that sort of did it justification, but essentially it's a 65,000 year whakapapa that he's put on the walls over 3 months, and quite a moving central piece. So I think the point is that the rest of the world is listening to Indigenous voices now, even if they're not being listened to quite as much at home. But Indigenous voices are valued, and yeah, Google Kith and Kin. It's a deeply moving thing. So that's me. I don't do Twitter or X or TikTok or Instagram. I think I am on Facebook, but I don't know how to use it. If any of you want to get in touch, I'd happily do so. I'd really value your thoughts on what we've done, what we should do in the future, what we've done wrong, if we've done anything wrong, and yeah, how we can continue to advance this kaupapa. It's important, and it's been possibly the best project I've ever been involved in my life. So thank you again for your patience. Nō reira, tēnā koutou katoa.